Whilst the numbers are important in understanding the size and nature of the challenge, the real cost is at the level of the individual child and family. By considering some examples of what early means in low and middle income countries, for the majority of cases, permanent childhood deafness identification is late. It becomes clear that if we are to avoid lifelong disability and enable deaf children to achieve their potential, very significant changes need to occur in terms of preventative measures. Early identification has to mean within weeks of birth, followed by services that help families and deaf children to live and grow together towards a positive future. Whilst there is an international agreement on the value and importance of early identification, for more than 90% of children in the world this is not yet a possibility. Now we're going to look at some case studies. CA, a child 7 years 10 months when she was first diagnosed with profound bilateral sensorineural hearing loss. This is permanent hearing loss. By this time, a normally hearing child would have the language of the home and be attending school. But as a deaf child, has no access to spoken language at home and is unlikely to be able to attend school as a result. Now we're going to look at a child 4 years 10 months old when first diagnosed with hearing loss. There were no behavioural responses when an incredibly loud sound of 95 dB was tried, and thus this child is profoundly deaf. Whilst parents had had some suspicion around the age of 3 years, this was dismissed, and they thought rather than being deaf, he was deliberately ignoring people and being rude. In fact, he was unable to hear any of the spoken word at home, warning signs, requests or commands. He could not join in any activities and was unaware of any plans made by the family. If we look at a further case study, this child was 6 years 4 months old at first diagnosis with a severe bilateral sensorineural hearing loss, thus permanent. But the type of hearing loss that could have been helped with the use of hearing aids if they were available. This child had no spoken language developed as he could not hear when anyone spoke, and they would be unaware they were communicating with him unless he could see their face. He would not hear games or songs and would miss out on all family chatter. Olusanyo undertook a study in an urban setting of Lagos, Nigeria. She found that whilst 12% of parents suspected hearing loss by 6 months, for a small percentage it took much longer, 4% suspecting deafness only when the children got to 5 years of age. The age of suspicion varied in the group generally between 12 and 24 months, but there was then a delay of 18 months between suspicion and confirmation. Even with identification of permanent childhood deafness, 80% of cases no hearing aids were provided. Very few enrolled in the school for the deaf by 6 years of age, leaving 94% of these deaf children not in education. A study in Kenya considered the state of early identification of hearing loss. First detection was delayed to 5.5 years. 57% of the children with hearing loss were detected after 2 years of age, but only 27% visited healthcare provider for assessment. 9% received counselling on hearing loss. None of the children identified with permanent childhood deafness received a hearing aid. In a study in South Africa, samples were taken in 2 urban settings, Western Cape and Gauteng. They identified the age of identification was delayed, but was within the first 2.5 years, ranged between 23 and 31 months. In both cases, there was a delay to hearing aid fitting. But on a very positive note, in both cases, there was referral to early intervention services. A rare example of a positive result of identification of permanent childhood deafness. Despite this positive example, it's important to remember more than 90% born with hearing loss will have no prospect of early identification and early intervention. Detection of hearing loss is primarily passive. Complications of middle ear disease, speech and language delays and unusual behaviour are usually used to identify deaf children. Lack of early identification, amplification and early service provision exacerbate the impact of hearing loss, consigning children to seclusion, limited access to education and home life, and poor quality of life. In seeking a way forward, Devet Svanopol reminds us of a quote, "Although the world is full of suffering, it's also full of overcoming of it." And this was Helen Keller. Helen was deaf-blind and can be seen here with her companion Annie Sullivan, who helped her access the world. Challenges are many, but by considering them, a positive way forward may be achieved. There's a shortage of hearing healthcare professionals. Limited audiological and otological health infrastructure. Both public and professional awareness and perceptions of deafness need to be challenged. Priorities on global and national health agendas need to consider the long-term global burden of untreated deafness, both to the economy and to the family and individual. The cost of services is particularly challenging within restricted resource environments. The contextual challenges, birthing patterns, cultural and environmental challenges are varied and require a sensitive and thoughtful approach. Solutions. The evidence provided by Svanopol et al. And Olasanya et al. Suggest a positive way forward. We need contextually relevant programmes for developing countries. Immunisation clinics are effective for babies born outside hospitals and provide a valuable platform for community-based newborn hearing screening programmes, where the long-term performance of the screen is comparable to hospital-based programmes. Risk factors can be addressed within primary healthcare settings. EDI must be integrated into maternal and child health initiatives in line with WHO, UNICEF and World Bank priorities. So, effective solutions. Cost-effective programmes for developing countries, there's an urgent need for evidence. One piece of evidence is the strong model of linking hearing screening with immunisation programmes. This has proved to be extremely effective, both in terms of coverage and cost. In terms of priorities, the first one is global, where we need global alliance of professional groups, NGO and NPOs. We need to reduce costs by global partnerships, public and private, to gain economies of scale for equipment, hearing aids, disposable items, batteries. We need pilot programmes at various levels and different systems. Education programmes for non-specialist personnel, including telemedicine, e-health, m-health models, training, quality control, diagnosis and intervention, and of course this MOOC. There is the moral obligation. The moral obligation for all of us to extend benefits of early hearing detection and intervention. To think about narrowing avoidable disparities. This is an important, pressing imperative. We need global attention to the silent, invisible epidemic. Better hearing for persons of all nations is an achievable, important goal. Urgency is for the most vulnerable, infants and children with hearing loss. By understanding the nature of the problem, we can begin to think about how each of us can take action to bring about positive change for deaf children and adults, the majority of whom have no access to services. And finally, I would like to thank Dr. Devet Svanopol and Phonak for allowing me to use these slides.